Our next speaker is Stacy Christiansen, who's a managing editor at JAMA and chair of the American Medical Association Manual of Styles. Stacy?
Hi, good day, everybody. I'm Stacy Christiansen, as introduced, managing editor of JAMA and chair of the AMA Manual of Style, which is a guide used to help encourage consistent style formatting and policy for medical journals and others in scientific publication and research. And just last year, we recently published a major update to our inclusive language guidance, focusing on terms and language used to discuss race and ethnicity in patients, study participants, and other articles that discuss health disparities, healthcare research, and education. So my comments are coming from a journal perspective. We believe inclusive language, of course, is very important. It supports diversity, conveys respect, and any language that imparts bias toward or against persons based on characteristics or demographics should be avoided. So our updated guidance on the reporting of race and ethnicity in medical and science journals was published in JAMA last August and is now freely available in the AMA Manual of Style online, and both are freely available online. The key principles of the updated guidance are, as others have noted, an acknowledgement that race and ethnicity are social constructs, not a biological category. However, the terms may be useful as a lens through which to study and view racism and disparities and inequities in health, healthcare, medical practice, education, and research. There are historical sensitivities and controversies related to language used to describe race and ethnicity. So it is paramount that researchers, authors, and journals be clear, precise, fair, and consistent in the terms that they use. Also, race and racism do not exist in isolation, and racial and ethnic descriptors should not be reported alone. So other sociodemographic factors and context should always be included as much as possible. This helps research into disparities and inequities in health, healthcare, medicine, and research. And finally, it should be abundantly clear in the reporting of research what the origin of the categories used is, who classified the individuals, what categories were available, and how these determinations were made, all of which should be clearly described. On this slide are some of the terms and categories that we use to define and describe race and ethnicity, which have changed over time, of course, based on sociocultural shifts and a greater awareness of racism in society. There is a concern about whether these and other definitions are appropriate or out of date, and whether separation of subcategories of race from subcategories of ethnicity could be discriminatory, especially if they're used by governmental agencies and institutions to guide policy, funding, budgets, and any data-driven decisions. These are some of the terms that we have considered new to our guidance, but that echo what several other people have already noted. The term ancestry refers to a person's country or region of origin. Another characteristic of many populations is genetic admixture, referring to genetic exchange among people from different ancestries, which may correlate with an individual's risk for certain diseases. And ancestry and genetic admixture may provide more useful information about health, population health, and variance and risk for disease than just the terms used for racial and ethnic categories. And a little bit of this slide just gives a little bit of the examples of some of the guidance that we have been developing. We advise avoiding biological explanations for disparities or inequities between racial and ethnic groups without recognition that these outcomes may also be intertwined with ancestry and heritage, other social determinants of health, socioeconomics, structural, institutional, cultural, demographic, many other features. There's a concern about some algorithms or associations because of how they were created or determined. For example, some of you may be familiar with the Framingham Risk Score, which was a calculation developed from largely a cohort of white middle-class individuals. So it may not accurately estimate risk in other communities and populations. Similar concerns have been raised about genetic risk studies based on specific populations that don't include participants from other groups. For example, a genome-wide association study that reports a genetic association with a specific disease based solely on individuals of European descent. We also advise avoiding provincial national government terms that may not be clear to international readers. For example, an article published in JAMA Cardiology last year used the term South African coloreds. So we came across that term and thought, what is this? We shouldn't use this. And we had to go and query the author who specified this was a group of individuals from a variety of different hunter-gatherer ancestries, and we were able to formulate a term, admixed African individuals, and describe exactly who those individuals were.
Okay.
Thank you for your time. More is available at amamanualofstyle.com.
Great, perfect. Thank you.